This is the first Leading Voices in Public Health lecture for this new calendar year. We are in our 14th year and have brought a number of different topics to the public here in Central Appalachia, but perhaps no topic has been more important than the one we're talking about tonight. This is the second coronavirus separating fact from fiction that we've had. The first was a couple of months ago and was extremely well attended, and we thought we would do one this evening on vaccines. I'm very, very pleased to be joined by our three panelists, Dr. Michelle Fiscus, who's Medical Director in Vaccine Preventable Diseases and Immunization Program for the Department of Health, Dr. Jonathan Moorman, who's Professor and Chair of Infectious Diseases for the Quillen College of Medicine, Dr. David Kursky, who's our Health Officer in Northeast Tennessee. All of them are extremely accomplished, and as you will come to know, have really put a lot of time and effort into mastering the challenges that face us all with COVID-19. Please be reminded that this webinar is being recorded. It'll be posted for later viewing. The previous one has been seen by over 1,000 times. So if there's anything that comes up tonight that you want to review later on, please feel free to do that. The panelists have been given the questions in advance that you submitted beforehand. And as you will see, most of those questions are being addressed in their comments. But we will take additional questions during the course of the presentation in the chat function. I will curate those questions. We'll hopefully get to as many of them as we can. We may not be able to get to all of them in the time allotted. Please, it's very important that you understand this webinar is not to provide you specific medical advice. If you have a medical condition or other specific question, please consult your healthcare provider. We can't provide that information to you. Again, just a reminder that we're focusing on vaccines tonight. We did receive some very important questions on treatment, diagnosis, other modes of prevention. We're not going to be able to deal with those this evening. But hopefully you'll get that information from other sources, including our COVID-19 website. And in fairness to all, this is not a forum tonight to debate issues about opinions of COVID-19 or vaccines in general, or government response or non-response. We really want to get your questions answered. And to that end, I'm really pleased. I'm going to turn the control of the panel over to Dr. Michelle Fiscus, who will share her screen and give her part of the presentation.
All right, thank you, and good evening, everybody. I'm happy to be here to share some information about the state's vaccine, COVID-19 vaccine response with you. You know, it's one of the most important things that we have done for sure in recent times. So for starters, we were required by the CDC to submit a plan to them back in October. It was actually due in the middle of October, and we didn't have a whole lot of guidance around how to write that plan at the time. So we called upon what was successful from the 2009 H1N1 pandemic and a lot of what we've learned around preparing for pandemics to draft that plan. And then we also used some of the resources that were available to us. For example, papers that have been written about how to distribute vaccines equitably to different populations. So our plan is posted to the web. You can go to www.tn.gov/health and then click on that yellow bar at the top, and then go down to that blue tile with the shield on it that says COVID-19 vaccine information, and you can find a link to the plan along with a lot of other resources that we have around COVID-19, around the vaccine itself, and you can find a link to the plan there that is always in draft. It always has that draft stamped across it. We update this plan about every other week. We just posted our 5th version of this plan on February the 16th, so just last week, and it'll probably be a week or two, and then we'll need to update it again. And it is very much an iterative process where the more we learn about how to roll out a vaccine to 6.8 million people in the state of Tennessee, the more changes and the more granularity we need to put into into that plan. So if you're interested, take a read. It's I think it's about 55 pages long now, but there's some pictures in it, and it's not completely boring to look at. But one of the things that you'll find there is this graphic that maybe you've seen before. This is our attempt to explain how we roll out these vaccines in one little snapshot. So this also changes with some frequency. When we first submitted the plan in October, the two of the things that are on this slide were there. One is that blue bar across the top that says equity is a cross-cutting consideration. And what we mean by equity is making sure that anyone who qualifies to get a vaccine should be able to have access to that vaccine, regardless of whether or not they have access to healthcare or insurance or transportation. If they are in phase at the time, we should be able to provide access to them. And we're very proud of the work that we're doing around equity in COVID-19 vaccine allocation and distribution. We've actually been lauded as the one plan out of the 64 states and jurisdictions that really has paid a lot of attention to equity, and that has been recognized by Vice President Pence and Dr. Redfield, who was formerly with CDC and others, and has received a lot of national attention around the emphasis that we put on equity. The other thing that was in the original version of the plan are these blue sort of stair-step bars that you see. And they've changed a little bit with respect to their content, but we began with a risk-based approach to prioritizing who could get vaccine first when we didn't have a whole lot of vaccine to go around. And so first and foremost, we wanted to protect that healthcare infrastructure. We needed to make sure that hospitals could remain open. At the time, we were very much surging towards what was the peak in our case counts. We were looking towards maybe having to stand up alternative care sites or field hospitals to take care of people who are sick, and we needed to make sure that we could protect healthcare workers to make sure that they were there to take care of those sick people. And along with them, we wanted to make sure that we could protect our first responders who had quite a lot of exposure with crowd control and all of the things that they do that are public facing. We then looked to, we split the federal phase 1A into two parts. So first to do inpatient healthcare, then to do outpatient healthcare, just because it was a little more manageable for us to handle it that way. And then phase 1B, focusing on teachers and childcare workers, not so much because of their risk of exposure or death or dying, but because of the importance of schools in so many aspects of our lives in Tennessee. So we know that we've had significant learning loss, that when schools close, it's usually because teachers are absent and schools can't operate safely when that happens. And so if we vaccinate our teachers, yes, we can lower their risk, but we can also help prevent them from needing to be quarantined and kept out of the classroom, and we can help keep the schools open. When we keep schools open, parents can go to work, children have meals and supervision during the day. There's a lot of reasons why it's beneficial to vaccinate those teachers. And then moving into phase 1C, which is individuals with high risk health conditions that place them at higher risk for having severe complications or death from COVID-19. And then the last of these phases is people who are living in congregate living situations. So those are college dorms and people who are in the correction system or in group homes where they could otherwise live by themselves, but for whatever circumstance are living in group homes. And then most recently, we just included the staff of overnight camps in that bucket as well. And that's not to say that the third phase is the least important or the last group to get vaccines. There are actually still millions of people behind even the third phase of this. It's just that we wanted to make sure that we were taking care of those healthcare workers, people who need to keep the state functioning, that critical infrastructure folks, and then those people who are at highest risk of transmitting disease. it wasn't very long before we realized that this framework wasn't really addressing what was driving morbidity and mortality, or hospitalizations and death in Tennessee, and that we really needed to also have some age-based criteria. And throughout this pandemic, it's really individuals over the age of 65 who have been driving hospitalizations and death in the state. And so that's when we put in these age-based criteria that move along independently of the blue bars, but beginning with prioritizing individuals who are over the age of 75, and then moving incrementally down as those individuals had an opportunity to get the vaccine. And really with the focus of wanting to stop hospitalizations and deaths from occurring. And we've done a very good job of getting vaccines into those oldest and most vulnerable people, both through the work to vaccinate individuals who are in long-term care facilities, which is part of the first phase, but then also in prioritizing individuals who are older and living independently, but who are at higher risk of hospitalization and death. So this is our progress so far. So in just barely over 2 months, we've had almost 1.4 million doses of COVID-19 vaccines arrive in Tennessee, and we've put about 1.1 million of those into arms of Tennesseans. And so that means that we've got about 81% of those vaccines in arms right now. We will always have some unadministered doses because vaccines land in the state 4 days a week, and it takes some time to get those pods operational, get those used, and then all of these vaccines that we have currently take 2 doses, and the facilities get those second doses about a week before they're due. So we're never going to be at 100% administered and 0% in inventory. As I mentioned on the previous slide, we have given almost half of these vaccines to people who are age 70 and older, and 62% of them to people who are 60 and older. So we've done a very good job of following our plan, and have more than 10.7% of all Tennesseans vaccinated with at least 1 dose of vaccine right now. We have vaccinated over 50% of the population of people in the state of Tennessee who are age 75 and older. So that is not only great uptake amongst that age bracket, but also speaks to the intentional way that we're going about vaccinating folks. So you've probably heard that there are 2 vaccines that are being used across the state right now. That's the Pfizer BioNTech vaccine and the Moderna vaccine. These are the only 2 that are available in the United States right now, and we have them both here. But the Janssen Johnson & Johnson vaccine is going to be reviewed by the FDA later this week, and then there will be a meeting of the Advisory Committee on Immunization Practices with the CDC this weekend to make its recommendations about the use of this vaccine. The reason we're excited about it is because, unlike the Pfizer and Johnson & Johnson vaccines, this vaccine can be kept in a refrigerator, and the Pfizer vaccine has to be kept under ultra cold, minus 70 degrees Celsius conditions. It's pretty fragile and fussy to deal with. The Moderna vaccine likewise has a short shelf life in the refrigerator, but the Johnson & Johnson vaccine can be kept in the refrigerator for months, and it only takes 1 dose instead of 2. So we're very excited to start getting this vaccine as early as next week and being able to deploy it across the state. I wanted to talk a little bit about vaccine safety because there's a lot of misinformation and misunderstanding about the organization that was formerly called Operation Warp Speed and what its role was in the development of these vaccines. So when vaccines are developed, they all go through these phases of clinical trials. Phase 1, where they start with a very few very brave people who volunteer to be injected with a vaccine that nobody's ever really used before in humans. And then in phase 2, there are more of those individuals, hundreds of them who sign up. And then in phase 3, we get to many hundreds or thousands, or in the case of these vaccines, tens of thousands of people who volunteer to be part of the studies. And once those vaccines move through those phases. They go to the FDA, the Food and Drug Administration, for licensure. And then after they get approved through that process, then the pharmaceutical companies start manufacturing the vaccines. And it's that part that takes a really, really long time, because this is a lot of capital investment for these drug companies. They might have to build factories, they might have to patent processes, they might have to contract with other companies to be able to produce those vaccines, and it's very expensive. And so they don't want to put this money into that production process until they know they have a vaccine that's going to be successful. What Operation Warp Speed did was take that that part of the manufacturing and the cost and the risk, and put that into a swim lane so that it runs parallel with the phases. So while they're doing phase 1, 2, 3 of the investigation of these vaccines, the federal government was putting money into the manufacturing of these vaccines, knowing that it's quite possible that some of the vaccines that are being investigated won't ever make it off and into anyone's arms. And we've seen that happen. The Merck pharmaceutical company had a couple of vaccines that were in trials. It turned out that they were not performing the way they wanted them to, and they were pulled. And so any investment that the federal government might have made in the manufacturing of those vaccines was lost. But what happened also is that this manufacturing that the federal government helped to support enabled us to have millions of doses of the Pfizer and then the Moderna and now the Johnson & Johnson vaccine readily available from literally 24 hours after these vaccines were approved, to be able to start getting them into the arms of Americans. So yes, phase 3 clinical trials, Operation Warp Speed did not mess with the science around these vaccine trials. Then also going through FDA emergency use authorization and the recommendations of the Advisory Committee on Immunization Practices. And then even after these vaccines are in arms, there's a very robust surveillance process through multiple entities to watch in real time to make sure that things that might not have been picked up with tens of thousands of people, but might happen in 1 in a million, are picked up and understood and investigated, so that we know that the vaccine supply that we're using is safe and effective. So I wanted to talk quickly about mRNA vaccines as well. So mRNA or messenger RNA vaccines are the Pfizer and the Moderna vaccines that we have out currently. And there's been a lot of chatter and rumor about these vaccines maybe taking over someone's DNA or reprogramming them in some way. And so I just wanted to take a minute to dispel any of those myths and misunderstandings. So everyone's probably seen this little picture of the coronavirus, and it has these little spikes on the outside of it, and those are called the spike proteins. And scientists were able to take one of those proteins and figure out the recipe for it. So if you think of it like your grandma's chicken salad, they were able to figure out exactly what this spike protein is made of, and they made a recipe for it. And that recipe is basically what is in the vaccine. So they put the recipe to make the spike protein into the vaccine. They deliver it to the muscle in your arm, and it teaches the cells there for a very short period of time to make the protein that is on the surface of the coronavirus. And in doing that, the body sees that protein and it says, oh, this is not part of me. This should not be here. I should probably get rid of this. And you make antibodies to that protein. What happens then is that when someday you actually do encounter the coronavirus, your body has already been prepped to see what that spike protein looks like. And those antibodies and other soldiers in your immune system are already there and primed, and they're on the lookout for it. And so when you see that virus again, those antibodies quickly attack that and prevent it from being able to make copies of itself in your body and make you sick. So there's nothing mysterious about these mRNA vaccines. It is simply a recipe to make something that is on the surface of the virus and then teach your body to recognize that and remove that threat. There is no coronavirus in these vaccines. They cannot give you COVID-19. They cannot cause you to transmit coronavirus or COVID-19 to anyone that's around you. And in fact, that recipe for the protein actually disintegrates pretty quickly. So you're not even able to continue to make that protein for any significant length of time. So who should get a vaccine and who shouldn't get a vaccine? There really aren't a lot of reasons not to get the vaccine. Right now, you can't get it if you're under the age of 16 because there just aren't any vaccines approved for that age range yet. 16 and 17-year-olds can get the Pfizer vaccine. Otherwise, you have to be 18 to get the Moderna vaccine. And if you had an allergic reaction to a component of the vaccines, or if you got a first dose of the vaccine and had a serious allergic reaction, you shouldn't get the second dose. But really, pretty much everybody else is able to get these vaccines. You might want to wait a bit, and there's a recommendation to wait a bit. If you had COVID-19 and you received monoclonal antibody therapy, or what some people might call the infusion, then you should probably wait 90 days before you get a vaccine, because that therapy can interfere with how you respond to the vaccine, and we want to make sure it works for you. And then if you've recently had COVID-19, you may actually be protected for up to about 90 days from getting reinfected. So if you can let people go ahead of you who might be at higher risk, that's great. You might also find that the closer you are to having had the infection, the more side effects you might have from the vaccine. So while those are temporary, it might make you feel a little yuckier if you're quite close to when you had your infection. There is a registration site to be able to get a COVID-19 vaccine through the health department if you are in one of the phases that are turned on right now. So that is those healthcare workers, first responders, workers in nursing homes, and now as of Monday, individuals who are age 65 and older, and teachers. You are able to get vaccinated now in Tennessee. Go to vaccinate.tn.gov, and there's a way there to sign up to get in queue to get an appointment. And in the meantime, it's still really important that we're doing all of those preventive measures that we've talked about so many times for the last year: keeping your distance, washing your hands, staying home with your sick, getting tested if you think you're sick, to make sure that we're not spreading this virus while we're waiting to get people vaccinated to the extent that we can achieve herd immunity and get local transmission decreased. So that's all I have for you. This is our public information line. If you have questions about COVID-19 or about the vaccine, you can call 877-857-2945, and we have a whole bank of people who are there ready to help answer your questions. They're available from 8 in the morning till 10 at night, Monday through Friday, and then 10 to 6 on weekends, and they're happy to answer any questions you might have. Thanks. I'll turn it back to you.
Thank you, Dr. Fiscus. That was outstanding. And just so folks know, while she was talking, there were a number of questions that were posed, and several of the panelists have been able to answer them as well, and others I've written down for later. So I'll turn it over now to Dr. Jonathan Moorman, who is sharing his screen. Thank you, Dr. Moorman. You're muted, Jonathan.
You'd think after all this time I'd be able to do Zoom. So thank you very much, Dr. Wyckoff, for allowing me to come and talk today. And I'm going to go into a little more depth about the vaccines that are out there now and some of the side effects that we've been seeing with them, because we get these questions every single day, all the time. And it's important for people to understand kind of how these vaccines are working and why we are pushing everybody to get injected with them. So here we are a year later, and we've learned a tremendous amount about the diagnosis, about the treatment, and now about the prevention of this particular coronavirus. But there's still a lot of things that we don't know. And I think it's going to take many years for us to really understand this the way we really need to. But you remember it was just a little over a year ago that we first realized that this beta coronavirus was much different than the other viruses that we deal with in terms of respiratory spread and in terms of morbidity and mortality. But it is, and always has been, a bat coronavirus that has a protein on it that I'll discuss a little more in depth that has a predilection for targeting the respiratory tract. As with all viruses, they get in through human cells, and in this particular case, it is that very important spike protein that allows for this virus to enter. It is absolutely fundamental to the virus for viral entry. And it is on the surface of the virus. That means this is part of what the immune system is seeing. And that's why it is the major target for almost all of the vaccines that we have going forward. It doesn't mean that other proteins can't be targeted, but it does mean that it's the most likely to work. And that's why they push forward with the spike protein as the primary target. It does get in through the ACE2 receptor, enters into the cell, the viral RNA is turned into proteins, and eventually it makes new virus and spreads. And it is at that point that the immune response can occur. It is not until the virus is actually in the cell that we can really stop anything with natural infection. But once it's in the cell, the cells are very good at recognizing foreign proteins, and they initiate a cascade of immune responses that lead to not only production of antibody, which we talk about so much. You know, are you protected? Do you have antibody? But it's not just the antibodies, it's the cells that are produced that are very, very important for clearing out the infection and also preventing future infections, hopefully upon re-exposure. So it's really not just what we call the humoral response, which is the antibody response, but it's the cellular response. So what we're doing with vaccines is really just mimicking that. And there are 3 types of vaccines that are currently in development that we use to try to prevent this particular infection. The first one Dr. Fiskus talked about is the mRNA vaccine that codes for the spike protein. And I want to emphasize again exactly what Dr. Fiskus said. This mRNA is very, very transient. It is encased inside a lipid nanoparticle, and it does not stay in the body very long. mRNA is very prone to degradation. It doesn't even live on a surface when we work with it in the laboratory because it just gets degraded so quickly. So I'm not worried about this being a long-term kind of ribonucleic acid that's going to cause problems. It doesn't last very long. It encodes the spike protein, and that is how this particular form of vaccination works to introduce it to the immune system. But every form we're talking about is really just a vehicle. It could be, you might think of it as like a plane, a train, a car, whatever. They're all doing the same thing. They're bringing it over to the host's immune response so that you can respond to it. The second most common kind of vaccine approach has been based on a viral vector such as adenovirus. These adenoviruses have been used in multiple vaccines before. They've been genetically modified so that they cannot cause infection per se. They can't go on to make more adenovirus. You're not going to get a cold from it. But what it does do is carry the genetic material for the spike protein into the cell so that once again, the cell can start making the spike protein so the body can recognize it and it can clear it out. The third way that we have up here is the protein-based way, where we just take the spike protein already made as a protein and inject it in. We have vaccines like that that probably most of you have gotten before that are protein-based, but those are not the ones that have gone very far in terms of getting to the public. So far, it's been primarily the first 2. So you all now know that the Pfizer vaccine and the Moderna vaccines are both approved in terms of emergency use access to use, and many of us have gotten them. The trial effectiveness was actually quite impressive for vaccines. It's unusual for me as somebody who sees a lot of vaccine trials to see these kind of numbers. So 95% efficacious is incredibly good in terms of preventing disease. So we're very, very happy about the ability of these vaccines to prevent coronavirus infection. The newest vaccine, which is going to be an adenovirus-based one by Johnson & Johnson, does not quite meet that kind of effectiveness, but was quite good at preventing hospitalization and death, in which basically nobody was hospitalized or died who got the new Johnson & Johnson vaccine. So these are all very, very effective vaccines, and that's very good news for all of us. In terms of side effects, this is a major issue. I've never seen a vaccine that doesn't have some side effect. It's just part and parcel of developing an immune response. But it is quite common to see things such as injection site pain, fatigue, headache, muscle pain, joint pain, chills. We see that quite often. It's more common in this particular scenario after the second dose with both Pfizer and Moderna, where the second dose is commonly leads to some significant side effects, but not enough, to require hospitalization or anything like that. These are very standard kind of reactions. There's always going to be people, always, that develop anaphylaxis to anything we inject them. I swear you can inject water in some people, they'd still have a problem. There's some people that are just always going to have trouble, but the vast majority of the people in the studies and what we're seeing now are doing fine. They may have a period where they don't feel well, but it is not something that I think is a reason not to get the vaccine. There's no evidence of effects on fertility. There's no evidence of issues in individuals with blood disorders. We do know that if you've had reactions to polyethylene glycol or polysorbate, you probably shouldn't get it. If you've had anaphylaxis to the first dose, you probably shouldn't get the next dose. Simple kind of common sense kind of approaches to that. But this is just an example of some of the data that we see from the Moderna vaccine. You can see that the second dose of the Moderna vaccine, the majority of people had some issue with it, be it fever, headache, fatigue, myalgias. I can tell you all of this is likely going to be better than a significant moderate to severe coronavirus infection, which you definitely don't want to get. So in terms of viral variants, I've had a lot of questions about that. Almost all of the viruses that we deal with have the ability to vary. It is normal for viruses to mutate. Some viruses do it a lot. If you look at HIV, hepatitis C, they're just constantly mutating, and we're always chasing our tail with them. Coronaviruses also can mutate, though not near to the same level as those viruses. And there have been, and there will be, multiple variants of coronaviruses going forward. These variants have been around since the beginning, before we even knew about coronavirus. They developed them rapidly. The variants that have appeared over the last few months that we've recognized appear to spread more easily and more quickly to others. There's 3 major variants that you might have heard about: the UK variant, the South African variant, and the Brazil variant. There are cases throughout the United States. If you look at data from the last few days, the UK variant has over 1,600 cases reported in the US. The good news is it looks like the vaccine, such as we have right now, including Moderna and Pfizer, are very likely to completely cover this particular variant, and so we have less concern for that. The South African variant is also in the US at lower numbers, and in some states. There is some concern about in vitro data that suggests, or when I say in vitro, I mean studies in the laboratory, that would suggest that maybe the vaccine doesn't cover it quite as well. I think that we don't know how it's going to play out clinically. It could be clinically these people will be completely fine. But in the lab, it's just not quite as robust at covering that particular variant. I think going forward, what we know from this is that we have to watch. We have to be very careful. We have to be looking for these variants. We have to look at people that might show up with a second coronavirus infection so that we can determine whether or not these variants are emerging. It is very, very easy with the current mRNA vaccines to modify that vaccine. It's quite easy to insert a different form of the mRNA so that it would cover those variants. So that's really good news. This slide is just really a kind of a summary of what we know about the vaccine coverage of variants. But the reality is there's a lot more we don't know. And I think going forward, hopefully we will learn a lot more about them. But I don't think people should get too hung up on them and too worried about them. I think vaccination is likely to be quite good at ameliorating certainly severe disease, and the disease we're really worried about. So vaccines are here. There are going to be many more to come. There are literally like 50 something that they're looking at, right? 250 something that they're looking at right now. So we're going to see a lot more going forward. Variants are expected and will require monitoring. And I think that if you really want to try to suppress the emergence of variants, you need to have high vaccination rates, high amounts of immunity in your populations, and all of those things will, of course, also allow us to get back to what we think is normal. So that's all I have, Dr. Wyckoff, if you want to have David speak now.
Thank you very much, Dr. Mormon. That was, as always, very helpful. And Dr. Kursky, you are ready to roll. If you wouldn't mind unmuting yourself and cameraizing, if you can.
Okay, you got me?
Yeah, looking good.
Okay, so some of the, well, Jonathan and Dr. Fiscus covered some of my material, so I'll try to skip I won't repeat what they've already said. I did want to give an update on what's going on in Northeast Tennessee region. So our region, Health Department region, does not include Sullivan County. So these numbers don't include Sullivan County. But so far we've given over 42,000 doses of vaccine in our 7-county health department drive-through sites. So that's our nurses and other staff out there doing these drive-through sites in all kinds of weather, snow and sleet, cold, wind. So I just wanted to thank all those people on the front line that are doing all this vaccination. As a state, Dr. Fiscus mentioned just over 10% of the state population has been vaccinated with at least 1 dose. All of our Northeast counties have vaccinated more than that. For instance, Washington County has vaccinated 17.3% of people with at least 1 dose of vaccine. And this is our health departments plus other community partners. So that includes hospitals and now pharmacies and other community partners that are also vaccinating. So I'm just going to talk a little bit about why we think people should get vaccinated. How do you get vaccinated? How long will the protection last? And what life after vaccination may look like? And I'll mention a little bit about the emergency use authorization of the current vaccine. So, coronavirus vaccine, as you've heard, has been shown to be highly effective, been carefully evaluated in clinical trials for safety, likely prevents serious illness even if you do get COVID. So like the flu vaccine, prevents hospitalizations and death. And it looks like coronavirus does as well, even if you do happen to get infected after you get vaccinated. And likely reduces transmission to close contacts. So that's important. It's an important tool for us to help stop the pandemic and try to get our lives back to normal. So the CDC recommends getting vaccinated as one of those tools to get our lives back to normal, but also to do all the other things that we've been recommending: wearing a mask, maintaining 6 feet distance from other people, avoiding crowds, washing your hands. So we still are recommending doing those other things, including after you've been vaccinated. We recommend to keep doing those things for a number of reasons. One is no vaccine is 100% effective. And the other reason is we don't know if people can become asymptomatically infected after you're vaccinated and still spread it to other people. So we do still recommend to do those things for the time being until we get more information about how these vaccines work in the real world. So this was a study that the CDC did looking at people's intention to get vaccinated or not get vaccinated. So they did a lot of interviews. So some good news is that as vaccines rolled out, people, an increase in proportion of people decided they were going to get vaccinated. So it went from 39% to 49% of people who said they would get vaccinated. Unfortunately, that number is below 50%. We would like to see that higher total, but at least it's increasing. And then people that said they weren't going to get vaccinated, that number decreased. A little bit of concern, especially in our region, People that were most likely to say they didn't plan to get vaccinated includes one, younger adults, women, which can't quite explain. Currently, women, about 61% of people that have been vaccinated are women currently, but primarily that's because of the groups we've been vaccinating, including healthcare workers. So you have a lot of nurses that are women and a lot of school teachers. The other thing is people in rural areas, so non-metropolitan areas, were less likely to say they were going to get vaccinated. And then people with lower education and income and lack of health insurance. So we do need to do some work with those groups to help increase their confidence in getting vaccinated. Dr. Fiscus mentioned how to get vaccinated. So that's a little bit more detail, but to figure out if you're in the correct phase for your county, and also to actually register for a vaccine, you can go to this website that's at the links at the bottom there. And you can actually request an appointment. And also this vaccine finder can help you know where the health departments are or other community partners who may be offering vaccines. So in our area, there are some Walmarts and other pharmacies that are offering vaccine. Hopefully soon, your doctor may have vaccine to offer as well. But it will be, you have to be in the right phase to get it at all these places. So they're not giving it to the general public outside of the phases we're currently vaccinating in each county. So in terms of vaccine, there's, we're still trying to determine, what the difference is between vaccine-induced immunity and natural immunity. If you have coronavirus disease, we think you do have some immunity afterwards. Unfortunately, getting coronavirus disease is not a great way to get immunity because it can cause serious illness and you have the risk of giving it to other people who can have serious illness. So vaccine is a safer choice. Again, it's been shown to be safe and effective, and side effects are generally mild. You may have a 24 hours of sore arm, maybe some low-grade fever, body aches. So one of the questions we got beforehand was about the need for a booster dose. So it's unclear how long natural immunity or vaccine-induced immunity lasts. Natural immunity, we think, lasts at least 90 days, which is the reason for some of the recommendations. We are continuing to study people after they get vaccinated to see if people get infected after vaccination, to see how long that vaccine-induced immunity lasts. Currently, CDC says the need for and timing of booster doses, so having to get another shot to increase your immunity, has not been established, and they are not currently recommending additional doses beyond the 2-dose primary series with the 2 current vaccines. One question is whether we will need booster doses for variant strains in the future, and that's being studied currently, whether getting a modified vaccine as a booster shot for these variant strains may be needed in the future. I'm going to skip that since Dr. Moorman talked about variants. So what is life after vaccination going to be like? So we do advise people not to kind of go crazy after they get vaccinated and do very risky things. So we basically, life after vaccination, we recommend most of the things we do before you get vaccinated. Again, vaccine efficacy is not 100%. And we don't know if people can transmit the virus being asymptomatically infected after they get vaccinated. So we do recommend people continue to follow CDC recommendations until we know more about vaccine effectiveness, including against variant strains, duration of protection. We also have to look at vaccination rates and coverage to see if we have enough people vaccinated to give us some herd immunity, which will make the whole community safer. And then the effects of the vaccine on transmission. So whether you can still be asymptomatically infected and transmit the virus after you've been vaccinated. So a lot of people have asked about quarantine after vaccination, and CDC just a week or 2 ago announced that if you've been fully vaccinated, so that means you've had 2 doses of the current vaccines, and it's 2 weeks after those 2 doses so that you've had a chance to build up as much immunity as you're going to get. and you're within 3 months of receiving the last dose in the series. So, after 3 months, there's less certainty about how long the immunity is going to last. And also, if you're asymptomatic, that you don't have to quarantine after contact, except in certain situations like with healthcare workers and things. So that's not to say that you can't get sick or you can't transmit the virus, but it's basically kind of a give and take kind of a recommendation. They say individual and societal benefits of avoiding unnecessary quarantine may outweigh the potential but unknown risk of transmission. So currently, if you've been fully vaccinated, you're asymptomatic, and it's within 3 months of your vaccination, your second dose, you don't have to quarantine after vaccination. I'll just mention that the 2 current vaccines are authorized but not approved by the FDA under emergency use authorization. Basically, because we don't have any approved vaccines, and this is a pandemic and a public health emergency, the FDA authorized them for use before they're fully approved. But as Dr. Fiscus says, there's still all of the safety studies went on before they were given. So the one question someone asked was whether, vaccination is going to be mandated, either by employers or other groups. So theoretically, employers can make it a requirement of the job to be vaccinated. I think it's unlikely that people will do that while it's still under emergency use authorization and is not fully approved by the FDA. We don't anticipate, anyone mandating that at this point, but it is a possibility. So we'll have to see how that goes. We did have some questions about, the Johnson & Johnson vaccine in studies was slightly less effective, which the manufacturer is saying is because it's been tested later while there's more variant strains circulating, and in places where variant strains have been circulating is the reason for the lower effectiveness. As Dr. Moorman said, all of the vaccines are essentially 100% effective at preventing hospitalization and death. And a couple advantages of Johnson & Johnson vaccine are that it only is 1 dose, so only 1 shot required. Some people may prefer that. And also it can be stored just in a refrigerator. So there may be, different places where this vaccine will be, more widely accepted and preferred by some people. For instance, someone that does not like shots and wants to only get 1 shot. So some good news, CDC has continued to study the vaccines after they were authorized and have been used. And it's a routine thing that the CDC does after a new vaccine comes out. So this study that was published just on the 19th, several days ago, indicates reassuring safety profiles for the 2 coronavirus vaccines that are currently being used. It did find that local and systemic reactions were common, like Dr. Moorman said. People get headache, body aches, sore arm after they get vaccinated. Reports of anaphylaxis have been rare. We have had a couple of instances in our region of anaphylaxis, primarily in people who have had anaphylaxis previously to another injectable medicine. There's been no unusual or unexpected reporting patterns of side effects, including no long-term side effects that have come to light at this point. And I will stop there and stop sharing.
David, thank you very much. Great questions and great information from all of you. Based on the questions that we received before and some that I've been jotting down since we've started, I'll start with Dr. Fiscus. A basic question that will come up quite a bit is, if I have had a documented case, I've been documented to have COVID, do I still need the vaccine?
Yeah, question does come up quite a bit. So yes, you do still need a vaccine because we know from the studies that we have so far that that natural immunity that you might get from that infection might be short-lived. We don't really know how long it lasts. There's been a difference in studies, but generally the estimate is 90 days-ish. I'll let Dr. Mormon comment if he has other information. But getting the vaccine will make sure that you have some additional longevity to your immunity, and will also make it less likely that you end up hospitalized or severely ill or dying from COVID-19.
Great, thank you very much. Dr. Mormon, both you and Dr. Fiscus mentioned serious side effects, if you have serious side effects from the first dose, but the side effects, what constitutes a serious side effect? And then
Apparently anaphylaxis would be the one we would be most concerned about. If you have a reaction that's that serious, you really, we wouldn't want to put you at risk for having a second instance of that. We don't see a lot of other side effects that are that serious beyond that with this vaccine.
one of the questions that comes up in that regard is, should people be worried about the particular component elements in the vaccine? If, for example, egg-based vaccines for someone who's egg allergic, are there any concerns like that with this particular vaccine?
I think one of the contraindications to it would be a previous reaction to polyethylene glycol, for example, PEG, which is one of the components, or polysorbate. If you already know that you have a problem with that, then we would not want to have you vaccinated again.
Dr. Kursky, this is more of a philosophical question, so I'll pitch it to you. For people that are on the fence about getting the vaccine, what approach should their family members or others take to encourage them to get vaccinated?
Yeah, I think just giving people accurate information is the most important thing. So people need to, understand the purpose for the vaccine, which we've talked about tonight, the safety of the vaccine, and then just, the rationale for getting it in terms of protecting yourself from hospitalization and death, and protecting others around you, and trying to, kind of establish herd immunity where we protect even vulnerable people in our community. But I think, yeah, just really accurate information for people, and, understanding that the side effects to the vaccine, sore arm, 24 hours of body aches, is really not that bad.
Thank you.
Can I just add something, Randy? From an immune point of view, as an immunologist, I want to remind people that our bodies are made for this. We are made to react to foreign proteins to protect us. It's just the way we're made. From the moment we come out to the moment we die, our body is trying to protect itself against foreign invaders. And all we're doing with vaccines is imitating the virus in terms of being a foreign invader. And I don't think people should be that fearful of something that our body does every day, all day long. If you can't do it, we see those patients. I see the patients that cannot develop immune responses. They get very, very sick. They are in the hospital. You need that post-immune response. It's normal. So I don't think people should be afraid of getting it in that they're taking something foreign into their body. If you go to any fast food place in Johnson City, you're going to be putting something foreign into your body, I can guarantee you. So
Dr. Mormon, is it fair to say if you do get a little body aches, you can feel assured that you're building your body's doing a good job of building a robust immune response?
The scientist in me says no, not until you've studied it. I don't know if that's true or not. You're obviously having some kind of response, some kind of inflammatory response, and we know inflammatory responses are better to develop post-immunity. The more inflammation, the more likely you are to have a response. So probably, but I'd have to study it.
So, Dr. Fiscus, another question that has come up a lot relates to, once you've been vaccinated, is it safe to go to the grocery store, fly on an airplane, do other things? Why do we have to continue to wear masks after we've been vaccinated?
Yeah, that's a great question. There's a couple of reasons for that. So one is that no vaccine is 100% effective at preventing illness. And so if you're on an airplane for 6 hours next to someone who has coronavirus and you're being pummeled by that virus, there's no guarantee that you absolutely can't get sick. The other is that we're still looking at whether or not these vaccines prevent you from transmitting the virus. So we know that they are 100% effective in the studies in preventing you from being hospitalized or dying from COVID-19. But what we don't know is when you get infected with that virus, while you won't progress to developing COVID-19, the disease that it causes, it's possible that virus still could be in your nose or in your throat, and that you could end up infecting someone who's next to you for a long period of time. So it is important both to protect you and the people around you. And then the third reason is that we are getting these new variants of these viruses that are shown to be more infectious, so not necessarily more dangerous, but more easy to spread from person to person. And the vaccines, while effective against those variants, are not as effective in a lot of cases as they are against the original SARS-CoV-2 virus. So there's a lot of reasons to still be careful to make sure that you're not the one that's contributing to the next case.
Great, thank you very much. And Dr. Moorman, a related question is, people are confused about how long immunity lasts, and why is the CDC saying only 90 days when, with most vaccines we think we're immune for a longer period of time?
I think it's because we don't have enough data. There are definitely cases where people have developed a coronavirus infection after having a coronavirus infection, and that was after 90 days. We know that there are some data in the lab that suggest when we look at people that they may have protective immunity for much longer than that. In some studies, it's still early, but some studies as long as a year already, it looks like we're protected. But I don't think we know enough about it yet, especially with the emergence of viral variants. I think we'll know a lot more in the next 6 months to a year. If you think about how much we've learned in the last year, it's just astounding. So I think we'll know a lot more and be able to hopefully move on once we know that data. But I think until then, we have to be very cautious because there definitely have been cases of people getting it again. And we're concerned about those kind of situations.
Thank you. Dr. Kursky, a couple of questions have come in while we've been talking about vaccinations in the African-American community, hesitation, and what do we know about the rate of uptake in those populations?
Yeah, so the CDC article that I pointed out did list African Americans as a group that's at least expressing less intent to get vaccinated. We are statewide and locally working to try to get vaccine to people, to groups that may not reach out to us. So we do have a strike team that, for instance, is going around to housing projects like public housing projects, to the elderly that might be shut in, to different groups like that, to try to make sure everyone that doesn't have transportation, can receive the vaccine if they want it. So we are definitely looking at that, and it is concerning. And yeah, we are addressing it. Dr. Fiscus, anything on the state level?
Yeah, sure. So, I think that it's really important for us to acknowledge where a lot of that hesitancy comes from. It comes from, a population of individuals who have been historically mistreated by the government, by organized medicine, back to Tuskegee starting in the 1930s. And trust is not easily regained once it's lost. And so we have a lot of work to do to build relationships. We have an Office of Minority Health and Disparities Elimination that works very closely with especially our African-American faith-based community to find ways to reach the community, to help to build the trust, to find the right people to share the message about the importance of this vaccine. And really try to work to bring the African American population to get vaccinated, because this is a population that is disparately affected by COVID-19. The deaths are higher, the morbidity is higher, the hospitalizations are higher, and at the same time, very hesitant to get the vaccine. And so that's a perfect storm for bad things to happen. And so there's some urgency for us to work with the African American community to help garner that trust and that interest in getting the vaccine.
Yeah, so I'll also add that, I don't know if we said it, but the vaccine is free and the administration is free through our health department site. So, lack of insurance or income, outside of transportation should not be a barrier for people.
Thank you very much. Dr. Moorman, a question that does come up a lot is related to long haul COVID-19. And I know this is supposed to be about vaccines, so I'll ask it in a way that has a vaccine part to the question, which is, what do we know about long haul right now? And do we believe that the vaccine will prevent some or all of those symptoms?
We certainly hope that they will prevent that. I think that it's very difficult to discuss it because we just don't know enough about it. We just don't know. It's too early, I think, to really be able to figure out what's going to happen with long-term with patients. We certainly have patients that have developed COVID that have symptoms that last for quite a while. I can tell you I have that with a dozen other viruses as well. But there's many people who suffer viral infections who develop problems after that with a lot of symptomatology that are very hard to treat. And I think COVID is just going to be one of those as well. I think it's a very interesting group to look at. I'm hoping that vaccine will prevent a lot of this from happening by just preventing cases.
Thank you very much. Dr. Kursky, questions do come in quite a bit about children and the vaccine. What are our current thoughts on whether is it safe to vaccinate 16, 18-year-olds? What are your thoughts on that? You're muted again. You're muted, David. Sorry.
Yeah, so Pfizer vaccine is authorized for 16 and up. We expect that all of the vaccines will be studied. Well, maybe not all of them, but we will have vaccines that studied in kids younger than that. And it will be an important thing for kids to get vaccinated, for us to get that herd immunity. Probably the more important, I don't know if Dr. Fiscus agrees, probably the more important group is young people like age 20 to 30, which tends to be most of our cases and transmission in our communities is occurring in that age group. So that's probably, I would think, the more important group for us to get vaccinated.
Thank you. Dr. Fiscus, a question came in beforehand, and that is, in the Tennessee phase-in plan, when would you expect higher education folks to fall into that?
Yeah, we get this question a lot, especially with the K-12 and childcare phase turned on right now. And so as I mentioned when we were going over that phasing chart, the reason that K-12 and childcare was put into an early phase was really not only because of the exposure of those teachers, but also because of the economic, social, developmental, educational needs of children and those families, and much more around an infrastructure role there. In higher ed, kids can go to college and or not, and parents can still go to work. You are able to do online learning much more readily than we are in the K-12 population. there just isn't the quite the impact that we see in the K-12 community as far as schools opening and closing and the learning loss that we're seeing in those young children. So as of now, the university staff, college and university staff, are phased according to their own risk phase. So as their age number comes up, or once we get through the third phase, then those individuals would be eligible. And a lot of that's community-based too. So our counties will move independently through these phases. While we just went to 65 and older and 1B statewide on Monday, there continues to be the need for some counties to move ahead of other counties, and that's actually part of the whole equity plan, is to give enough vaccines to especially high-risk communities so that they can vaccinate their population a little faster than communities that are more well-resourced. And so there may be counties that move to 55 or counties that move to 1C when other counties may not move quite so quickly. So it also depends on where you live and what your community is like as to how quickly we move through those phases.
Thank you. Dr. Moorman, a question has come in while we've been here, and that is, do we understand do we have any idea why the new variants are more communicable than the original, or why it may appear that they have some increased lethality?
I would suspect that the mutations led to an easier binding of the spike protein to the ACE2 receptor, because we know from just looking at it that the virus is not adapted perfectly to us yet. It could do a lot better in terms of binding to that ACE2 receptor. So probably there was some kind of advantage for it to bind to that receptor and get in a little better, a little stronger. So I think that's the reason. I don't think we really know. It's real hard to tease out, really, really hard to tease out why. But we could do some, binding studies to see if that's what it is.
Thank you. Dr. Kursky, a question came in about whether or not our county or state data includes vaccinations given at the Veterans Administration Hospital to their staff.
I'm pretty sure that if you go on the map and look at our percentages, that all comes from the vaccine registration system that we have. So it should include anyone that's, based on where they live, that's gotten vaccine. And I believe VA is participating in that. Dr. Fiscus.
The Veterans Administration does not consistently report or reliably report to TEMIS, to the State Immunization Registry. So we get aggregate data from the VA, but we don't get individual level data from the VA. So the numbers that we're reporting are likely excluding VA unless those individuals were vaccinated somewhere else.
Dr. Fiscus, I'll stay with you on this next one. Are you having a problem statewide with getting people to get their second vaccination?
We don't seem to be. We certainly have a lot of interest in getting vaccines, and so there are lots and lots of appointments for people who need first doses and lots of appointments for people who need second doses. So they may not be getting those second doses right at day 21 or 28. And that's okay. The CDC has clearly said that we've got 6 weeks from the time of the first dose to get the second dose. When you look at our metrics, we actually have almost to the one an equal number of individuals who've gotten 2 doses as we have individuals who've gotten 1 dose. So, so we think people are doing a pretty good job about coming back and getting their second dose.
I'm reading my questions here, and my handwriting is getting a little ragged here. There's quite a few questions about whether or not there would be any benefit. Maybe Dr. Moorman can take this. Any benefit to thinking about mixing types of vaccines? If you've had an mRNA, should you take an adenovirus? Is there any sense that that might provide additional protection?
I guess theoretically it could, that it's certainly not recommended that we mix. For example, I would never have somebody start with Moderna and then go straight to the Pfizer. That they're not recommending that because it's not how it was studied. These are all done in very large clinical trials that are controlled so that we know what the result will be. I think if you're going to start mixing and matching, you're going to have to do some studies to show that it's safe and effective to do that, because you just don't know. You're introducing a lot of unknowns. I do think that they'll be adding variants at some point, but that's a different issue and probably more as a booster.
Yeah, and that's what I was going to say.
And this is another, maybe Dr. Kursky, I can refer this one to you because it's another difficult one. When new types of vaccines are available, how will the decision be made of whether someone gets an adenovirus vector or mRNA?
Yeah, so I'll start out and just say that, we don't expect that the CDC is going to recommend one vaccine over the other. And vaccines are probably going to be distributed within our region based on people's, our providers' capacity to store and give the vaccine. So, providers that don't have, aren't sophisticated about storing and keeping vaccine at the right temperature and things like that, would probably be more likely to get something like the Johnson & Johnson vaccine once it's approved, or not approved, but authorized. So then when people go get vaccinated, it really will be, for instance, with our vaccination sites, people don't necessarily know for their first dose if they're getting Pfizer or Moderna. They get invited to the first one that's available for them. So, that's going to be part of it. I don't know if Dr. Fiscus has other thoughts about that.
I think you're spot on. As the group that does the allocating, that's exactly what we take into account. Is the Pfizer vaccine, as I said, is a little fussy to handle. The Moderna vaccine can be a little bit too, and so we're a little bit limited in where we can give, especially Pfizer vaccine, mostly to large health departments and big hospital systems that can handle that vaccine. The Moderna vaccine is not quite as complicated to deal with, but it still really needs to be with people who are accustomed to dealing with vaccines. And so, still health departments, medical offices, hospitals. And then the J&J vaccine is just not as complicated. And we can feel a little bit better about giving that to places that don't routinely use vaccines or work with vaccines. The training's not as complicated to work with that one. So it very much depends on the quantities that we get of each of these vaccines, the number of partners that we have that are able to deal with each of those vaccines and administer them and keep them safe so that we're sure that they're effective.
Thank you. This will be a toss-up question because I know it's a tough one to answer. But it's someone who's obviously has been vaccinated now and is in their 3-month probable immune phase. Is it safe for them to take a plane ride and visit their grandkids?
Tough one.
So I guess, CDC is still recommending that people take the same precautions they did before they got vaccinated. As I think all three of us have said, no vaccine is 100% effective. Really, you're taking a chance. It's one of a number of tools that we have that we think people should use. We recommend you get vaccinated, but we also recommend that you do things to stay safe. And probably you should just consider, how important it is to travel, because there still will be some risk associated with travel.
This may be too specific a question, but someone said they got their first dose of the vaccine and then they were diagnosed as having COVID and told to wait 90 days before do they have to start again, or can they get their second dose, or is that something they need to refer to them?
Yeah, so we do recommend that they get the second dose. They do not have to wait 90 days. We do recommend people don't come to get vaccinated while they're still in isolation. They should stay home and probably wait till their symptoms resolve before they come. But then they should get their second dose. We're still recommending they get it within that 6 weeks window after their first dose, but not come out in public while they're supposed to be in isolation.
Yeah, I'll just add that the caveat to that is if as a result of your having COVID-19, you received monoclonal antibody therapy or the infusion, then you should wait 90 days because that can have an impact on how well the vaccine works for you. But as Dr. Kershke said, you don't have to wait 90 days before you get your second dose if you did not receive monoclonal antibody. But there are reports of people who have more significant side effects the closer they are to their time of infection. So basically, if you think about it, like your infection was almost like another dose of the vaccine, and then if you go plow another one right on top of it after that, you're probably going to be more likely to have body aches and fevers and chills and feel really rough for a few days. And so since you're in that window where you probably have some protection, if you wanted to wait closer to the end of that 6-week period, or even as long as 90 days, you're probably fine to do that.
And Dr. Fiscus, this may be a question for you as well. Some states are using iPhone registries to know where people are, where they've traveled, and so on. Has Tennessee thought about that, thinking about it, may do it, may not do it?
We've thought about it. As a state, it gets a little big brothery to think about, someone pinging your iPhone and notifying you. We have not rolled something like that out as a state. There have been some universities that have used something similar to that, an application that where someone scans a QR code as they go into a classroom, and it puts a timestamp so that when you're in and out of the classroom if there ended up being a case. Honestly, now with our case counts as they are, we're right now back to where we were in June with respect to case counts. And so hopefully we're going to continue between the vaccine and all of the public health measures to see those case counts go down and for this to continue to be less and less of a player over time. But the short answer is no, the state hasn't. We've considered it and decided that wasn't a direction that we wanted to go in.
Yeah, so I'll just add that for anyone interested, the NFL actually used something like that to very good effect, where they actually had GPS devices on the NFL players so that if someone did get coronavirus, they'd know exactly who they were near and for how long so that they could effectively isolate people. That's been reported in the MMWR if any of the public health students want to go look at that report. But it was basically kept the NFL going for the season through the Super Bowl. Because they took some pretty, outside the box measures.
Another question that's come in. Is there any way to know which vaccine a local pharmacy has, Moderna versus Pfizer, or is it, as you say, David, just the luck of the draw?
So in general, it's going to be Moderna vaccine, especially if it's a small community pharmacy. We have a couple pharmacies that are large pharmacies that are going to do large vaccination events that may have Pfizer vaccine, but I would say probably 90% of the pharmacies in the state that have vaccine have Moderna vaccine.
Yeah, part of that's effect of storage, but also Pfizer vaccine kind of comes in units of about 1,000. So you don't necessarily want to give that to a small pharmacy that can't get it into arms, fast enough, and it would potentially go to waste.
And another question we've seen a couple of times, is there any way to know that a vaccine was kept at the proper temperature when it's finally distributed to you?
There are measures in place to make sure that all of the facilities that receive vaccine have the appropriate storage and handling equipment. So all of these vaccines are monitored with what's called a digital data logger. So there's a box that's put on the front of the freezer or the refrigerator, and a probe that's put in the refrigerator with where the vaccines are that continuously monitors temperature 24/7. There are alarms that signal if something's gone out of temperature. There are reports that are downloaded that show if there's alarms, and we take that very, very seriously. So you can't even get an allocation of vaccine unless you've jumped through all of our hoops for how you store it, where you store it, what type of refrigerator or freezer you're using to store it, that you're going to report all the vaccines that are administered to us, that you're going to track your wastage. We monitor their inventory to make sure there isn't vaccine sitting around. So there are a lot of measures in place to keep that vaccine as safe as we possibly can.
Yeah, I'll just say on a local level, we, basically at our vaccination sites, we have one nurse that all she does is sits there and hovers over the vaccine, monitoring the temperature and taking out of the refrigerator or freezer at the right time, and making sure it gets back in the right time. So
I promised I wasn't going to ask any non-vaccine questions, but David, you opened the NFL door, and someone says the NFL used dogs at the Super Bowl to sniff out COVID. Was this scientific?
I've not heard about that.
Maybe the dogs had been vaccinated.
I've heard about a dog that can sniff out melanoma, but I don't know about coronavirus.
Well, we're coming to the end of our time. I want to thank everybody. Hang on, I appear to have lost. I'm supposed to show you a couple of more slides here. They seem to have disappeared on me, so let me. Okay, here we go. There we go. Can you all see that now?
Yes, we can.
Okay, well, first I want to thank the three of you. I mean, you give a tremendous amount of time. I suspect the audience realizes how much effort you put into making sure that your prepared comments addressed most of the questions that we got in advance. I was a little worried for a while that I wasn't going to have enough questions to ask you, so thank you very much for that. Most of you should know that I do a weekly update on the progress of the pandemic. They're posted on our College of Public Health website. Not only do I do the progress, but I try to answer questions that may have come up. If you know anyone, or if you'd like to be added to that, please contact Ms. Stork at storkj@etsu.edu. I've already finished that. And just a reminder that the next Leading Voices will be exactly 1 month from today. Dr. Kara James, the President and CEO of Grantmakers in Health, will provide the first Health Equity and Inclusion lecture, a new lecture that we're adding to our portfolio. If you have any comments or questions about tonight, please feel free to contact me. I apologize if there were any questions we didn't answer, but let me close by thanking our panelists for really an outstanding event. Thank you all very much. Have a good evening,
Thank you.
everyone.